So for those folks who are going to be tuning into this, Dr. Habib and I have been friends for some time now. He's somebody that I admire a lot, and I would like to say maybe the feeling is mutual, but we'll
For sure.
that's to be seen. But I just wanted to give everybody an opportunity to hear a little bit about who you are, what you do,
Perfect.
and then I'll share a little bit about myself.
Yeah.
So why don't we start off there?
Yeah, likewise, actually, the feeling is mutual. I think the fact that we do have a lot of mutual respect for what we do, I think that's kind of the reason why we're doing this together. My background is that I'm a medical doctor, graduated in the UK in 1993. Believe it or not, that's a long time. So I've been a physician for 30 years. And you'd imagine that the things we're going to be talking about is something that we were taught in medical school or I'm reading in my medical journal. And the fact is, it is not. That's unfortunate because what we're going to be talking about is the real medicine. And by the time we're done with this conversation, you're going to rethink everything you thought you knew. This is going to be something that we're going to do on a regular basis. And this is where we bring in the things that you do at home, the real world, into the medical world, the way it should be to get results. So the medical world is the only world where the results don't matter, because if the doctor gets reimbursed, it's good. I don't work on that reimbursement model anyway. Fact is that my job isn't done until the client gets results. And until they do, everything that I do is related to my medical practice. That means when I follow up with them, if I give them tools, this kind of scenario where we're educating people, every tool needs to be brought to the table to get results. That's when a doctor's job is done.
Yeah, and I agree
And
with that. And
so,
I think that I think that's something that's been lost, and unfortunately, or actually fortunately, there are people like yourself who are trying to kind of bring that new school of thought and understanding to the forefront of medical practice, because just like a lot of things, um, you want to be proactive in your approach to your health and your wellness instead of reactive, which so much of our traditional medicine is reactive in that sense. Just a little bit about myself before we start
no,
getting.
I'm going to talk about you.
Oh,
So,
okay, all right, come
yeah,
on.
yeah, because,
You gonna roll out the red carpet?
yeah, moving from here on, I'd be talking about myself. But listen, the reason Vic and I are doing this, as I have said, that we've known each other a long time, and the fact is that you're so knowledgeable, and that's what matters. It doesn't matter if you have a license or a name behind your letters behind your name. It doesn't matter unless you get results. So with Vic, not only do you have somebody who's knowledgeable, he actually practices what he preaches. Right? I want to be like Vic. I want to be able to work out like him. I want to understand nutrition like him or be disciplined like him. This is a guy that uses sauna and he's only in his 30s. So he's figured out things that we took decades to work out, but he's incorporating them. And the fact is that, if, with all due respect, if Vic can do it, then we should be able to do it. That's the point. And your doctor's not practicing what he preaches, so don't be listening to somebody. I got to be careful about this. Everything we're saying here is for education purposes. You should respect your doctor. Go to your doctor for advice. and But the point is that you may want to ask him some hard questions like, do you practice what you preach? And what you preach, is it actually accurate? And if it's not aligning with what Vic and Dr. Habib says, you may want to rethink it. Oh, by the way, next help is rethink medicine.
Yeah. Well, so thank you for that. Yeah, I think that we all should be in the practice of practicing what we preach, and so many people don't. And I think that it's very hard for you to be able to, one, as a patient or a client, a customer, a consumer of any product or service, to take without a very large grain of salt what somebody has to say if they're not implementing the strategies that they're suggesting you do for themselves. That should be a huge red flag. The other thing is, I like what you said about asking physicians, and anybody for that matter, hard questions about the suggestions or the protocol that they're prescribing you, because at the end of the day, you shouldn't just take even a professional's word for just that, right? You should be a little bit, you should be willing to ask some questions and to do a little bit of research and at least critically think about what's being presented to you as an individual before you just follow along suit. So actually today, what I wanted to pick your brain on a little bit, Doc, is a couple of patients that you and I are working with together, who shall remain nameless. One of the big concerns for us in our discussions when we were doing a little bit of our consulting with one another, was blood pressure. One of these individuals is a female, one of them is a male. The male has some moderate blood pressure concerns, and all of the heart health cardiovascular health concerns that typically come along with that are for him a primary focus, right? And one of the questions that I think he asked you during your initial consult was, how do I know when I'm pushing too hard? How can I make sure that I'm not elevating my blood pressure to the point that it's dangerous when I'm exercising? And you and I both agreed that it's very simple. You need to listen to your body. Now, with that being said, there are some things to consider in terms of not just exercise prescription, not just nutrition prescription, but psychology. What are some of those driving forces behind what are actually the underlying causes? And that is one of the things that I've always admired about your practice and the things that you do, is that you try to dig more deeply into, okay, we're not looking at what's the problem that's presenting itself. We're trying to look for the root cause of the problem that is presenting itself, because that's really the only way that you can actually make long lasting and significant change, right? So why don't we talk a little bit about some of those things that you mentioned when we were on the phone, in terms of some of those underlying causes that a lot of people tend to overlook and don't even think could be the cause of, say, elevated blood pressure.
So one of the reasons I have Vic here is that I tend to talk at 100 miles an hour, and Vic, as you can see, is the calm, collected guy, which I suppose I should be, but I have just too much to say. So I'm going to try to control myself, but let's get started. First of all, what is the definition of blood pressure? It's basically 3 readings where you have a high numbers in the systolic, the top number, the diastolic, the bottom number. And those numbers have actually come down and they're still calling it hypertension. So it's like 135/85. If you are 135/85 or more, then you are sort of classified as hypertensive. But let's start with that statement, right? You're rushing into a doctor's office, right? Waiting forever, stressed out. You're rushed into an exam room, and a medical assistant straps on a blood pressure cuff. And is it the right size cuff for the right size arm? And then they quickly write down the blood pressure reading, leave the room, and wait probably, God knows, another 20, 30 minutes before the doctor comes in. And let's assuming it's about a blood pressure, he's going to go based on that reading. So I know this may not be exactly where we're going to go, but let's just start with the basics, because how do you know you have a diagnosis? Because somebody told you. So let me tell you something, and I'm going to give you a scenario. If you rushed in and you're stressed out and you're anxious and you got a meeting and you got all this on your mind, what might happen to the blood pressure? So that's why we have 3 different readings, right? 3 different readings on 3 different occasions. But is the doctor's office the best place to get those readings? I propose to you, probably not. Because what we are trying to decipher is that, when is blood pressure really blood pressure? When is it reacting to something? So let me give you a scenario. I told you I'm going to talk fast, so stay with me. But you can always, this is a recording. You can record over and over, just over and over. Then you probably shoot yourself listening to Dr. Habib over and over. But follow me over and over, which is this. What is your blood pressure when you're sleeping? I'm going to tell you the answer. But once you think about it, what's your blood pressure when you're on a treadmill going at 8 mets, which is fast for me, maybe slow for Vic?
No.
Yeah, it's pretty bad. It's
relative.
Not bad. 8 mets is pretty good. Right?
Relative.
Exactly. I'm going to try not to give any sarcastic remarks.
That's okay. Be you. No, be you. I like you for who you are.
I won't be able to help myself. You know me. So, well, let me give you that answer. And then we'll go back to the doctor's office. And then what is reactive blood pressure? So your blood pressure is a number, and doctors treat it. We should not think of it as a number that we treat. What we should think about is, why is the body raising the pressure? Generally, we talk about high blood pressure. Today, we'll talk about high blood pressure, which is the majority. There are situations where you can be hypotensive, low blood pressure. They're rare, thank God for that. That's much more complicated. So
just to interrupt you for 1 second, I have a question. So some of the stats that you see out there tend to circle around this idea that roughly 25% of the population are hypertensive, quote unquote. Do you think that number is accurate, or do you think a lot of that is due to, like you said, poor protocol in assessing blood pressure? Or do you think that number's higher or lower? What do you think?
Yeah, well, my definition of blood pressure is not waiting until the blood pressure is 135/85. In fact, because you asked, what we want to know is how soft are the blood vessels, which is the crux of why we would manage, control, treat someone's hypertension. Right. So if the doctor does not have the tool to measure the softness of the blood vessels, he's really guessing. That, by the way, is not called evidence-based medicine. They love the word evidence-based medicine, yet they don't practice evidence-based medicine when it conveniently suits them not to. So they believe.
Red flag.
Yeah, when I say they, I mean, I am a physician, but unfortunately,
Sure.
they are the lower level and this is the higher level. And this is what patients should expect, is the higher level physician to ask the question, doctor, do I really have blood pressure, or is my blood pressure reacting to something? They're not the same. At the end of the day, are we trying to lower the blood pressure because the number is the problem, or because the high pressure eventually makes the blood vessel stiff? We're going to talk about what does stiff blood vessels mean. A little teaser, nitric oxide. So if you don't know if your blood vessels are soft or not, that is a problem. And so that's the whole idea of so-called diagnosing, right? So going back to what you said, do I wait until it's 135, 85? No. If I see stiff blood vessels, I'm going to work on the nitric oxide, and we're going to talk about the medical way to do it through the gut, through the exercise, through the nitrite system, the enzyme NOS. We're going to talk about it, and we'll slow it down for the complicated parts, but we're going to still say it the way it is. And then, so the point is, do you really want to wait until you're sort of pre-hypertensive? The answer is no. Is there a drug for pre-hypertensive? No. We're not supposed to, evidence-based, treat something that you don't have a diagnosis. But, you know, when the mindset of these people is, well, we should.
Right.
Anyway, the point is that we don't wait until it's hypertensive. So let's talk about reactive, right? Go back to what I said. When you're sleeping, what is your blood pressure? You wouldn't know. But if you're a doctor that's been rounding the hospitals in the early days, which is about 25, 30 years ago, but nevertheless, I remember everything, is that the blood pressure would be like 90/60. Now, are you dead? Because the nurse will call you as a young doctor and say, doctor, the blood pressure is really low. And I would say, nurse, actually, I'm being melodramatic. Are they breathing? Yes. Yeah. Well, leave them alone. They're sleeping. There you go. Now, because I'm a seasoned physician, I can get away with that rough statement. But in those days, if you were rough with the nurse, oh, they would be rough with you, and you're going to regret it. Sorry, I'm shaking.
That's okay. I see. Look how excited you are, man. Your computer's getting nervous.
Yeah, exactly. Let me calm it down. What is the blood pressure when you're on the treadmill? Well, guess what? I never got taught in medical school. So I got on the treadmill and I went to like 9 meds and 10 meds and I measured my blood pressure. It was in my 30s, so it may be a little different now.
Right.
It was like 210/140.
Yeah. Right.
Am I going to have a stroke? Let me repeat that again. Am I going to have a stroke? No. So that's why today, by the end of this conversation, we're going to be able to guide you as to when is the blood pressure too high, how to really, work out. But again, everything I just said is based on my physiology, right? If I was a cabbage potato, whatever, lazy bum sitting on a couch, and then I went to 10 meds and my blood pressure was 210, it's not quite the same as somebody who's regular in exercise and what type of exercise, cardio or strength. And then how do you nourish your body with the nitrates? How do you protect your NOS, the nitric oxide synthase enzyme? It's about protection, right? So let me just stop and let you ask some more questions.
No. So from an exercise prescription perspective, right? That's I didn't have a chance to mention this, but my background is in exercise physiology. I've been involved and educated formally. I have a degree in exercise science and exercise physiology. I've been practicing in all different aspects of health, wellness, and fitness, everything from sports performance to, like you said, chronically ill, general population individuals. But in terms of exercise prescription, one of the things that you're taught early on is just like what you alluded to, is that there are these acute spikes in both intra-exercise, so during an exercise session, and post-exercise blood pressure, right? But that's a natural response to the exercise itself. But what people fail to realize is that is sending the body a signal and priming some of the systems, both cardiovascular and otherwise, to downregulate the resting blood pressure, right? So there's this acute short-term increase in blood pressure while you're working and even shortly thereafter. But what that does over time with consistency is that brings your resting blood pressure down. And again, like you said, resting blood pressure, you could define that any number of ways, but just generally speaking, you're walking around day to day. When you walk into the office for your checkup and the doctor comes in and you're anxious and you're stressed out, that number may with time start to drop. And for most people, like our patients that we were referring to earlier, one of the major concerns is for you guys, when you're doing your assessments, your executive physicals, one of the panels that you run is a cardiovascular health panel. So that looks at the triglycerides, cholesterol, all of these things that are generally known to be correlated to cardiovascular health. And that's a whole deep rabbit hole conversation that we'll have at another time. But people get caught up on those numbers and they really want to understand, how can I lower my blood pressure? Can I get on a pill? What can I do? Something as simple as regular exercise, 20 to 30 minutes, more or less, it doesn't matter, can begin to lower that number. And what they find in a lot of the research, some of the data points to something as small. So again, just to back up a little bit, blood pressure is measured in millimeters of mercury, right, which is just a unit of pressure. You have your systolic, which is the top number. You have your diastolic, which is the bottom number. Both of those numbers elevate with exercise, but both of those numbers can decrease with time. Just a drop of 2 millimeters of mercury has been shown to have a 6% decrease in mortality caused by stroke, and a like 5% decrease, 4% decrease in mortality linked to cardiovascular events. But if you take that number, that 2 millimeters, and you take it and you turn it into 4 or 5 millimeters of mercury, now you're looking at a 14% decrease in cardiovascular events and a 12 or 13% decrease in some of these other aspects. Oh, excuse me, 9 and 14 respectively. But the point is that there's a compounding effect to this stuff. So with consistency, you can begin to generate better and better and better results, just like some of the proactive approaches that you guys take in the clinic there with different treatments, things like hyperbaric chamber, all of these different IV drips. With consistency, you can build momentum and you can start to gain greater and greater and greater health results. So I just wanted to say that because, again, sometimes people are interested in what the numbers are. And it's like, I need to see something that's cut and dry to put it into perspective. But there's some real significant, and again, to be honest with you, doesn't really matter if it's what the modality of your exercise is. Sometimes the duration isn't even that much of a factor, but the fact is that with consistency, you can see dramatic change, and the long-term implications of that change are what we're really after. And then one final note on that is, because you and I, we also discuss pretty in-depth nutrition with the patients that we work with. We know for so many reasons that is a foundation of our health in a lot of ways in terms of how it affects our gut, and our gut is, the epicenter of all that goes wrong in the body, generally speaking. At least in my opinion, I think that's where a lot of the things start to go wrong, right? You are what you eat. So that makes sense, right? You put things in your body, it affects where that stuff goes. And then that is where everything starts to stem from. But in terms of nutrition, they find in some of these research studies that when somebody is obese or overweight, that the results are hindered to a degree, right? So there is this correlation, and it's multifaceted, and it's deeper than just being overweight versus not being overweight. But they find that if you are overweight, so again, if you're not managing your nutrition properly, you're not doing things to keep your weight in check, you're not exercising regularly, then you also are going to be fighting a more uphill battle in terms of being able to yield the results that we're hoping to help patients achieve with proper exercise, proper nutrition, let alone things like IV drip, these alternative modalities, these alternative therapies that actually have a lot of potential and a huge amount of power, not just to make us feel good, but to actually make us better. So I just wanted to share that real quick.
Yeah, well, I mean, look, there's so many good things to talk about, but just to back up, and the fact that you brought up so many things shows you that blood pressure is not just a blood pressure. It's really a barometer of overall health and wellness. So if you follow not only this program and the subsequent ones, you'll see us coming back to the blood vessels, because you're only as old as your blood vessels. So the health of the blood vessel is the crux of it. Controlling the blood pressure, as you alluded to, can reduce the risk of stroke and heart disease. So nobody's saying don't treat it, but how to treat will be dependent on the root cause. So 3 people with blood pressure can have 3 causes, which I'm going to go into in just a second. But first of all, let's go talk about the one that is the how we diagnose it in the doctor's office. Generally, those people have a family history, and the doctor is resigned to telling you it's in your genes, which is false. The next one is a reactive blood pressure. And an example of that is what we said. If you're sleeping, you're not demanding blood flow to the muscles, so the pressure does not need to go up. When you're exercising, you need to get oxygen into the muscles because it's going at 8 mets or more. So in order to get the oxygen to the muscles, you need blood flow. The only way the blood can get to the muscles is through pressure. Now, extrapolate. What I'm trying to say is that your blood pressure is being regulated based on what the body deems. Over a period of time, because of genes and bad lifestyle, like nutrition and so many things we're going to go into, you end up getting diagnosed with blood pressure. When you get diagnosed, you can either just control it, or you can say, well, these are the steps that led to my blood pressure, like low nutrient levels, low or inflammation, or insulin resistance, or low nitric oxide. It's not just nitric oxide. There's a lot of players here. But the fact is, the bad lifestyle damages all the players, then allowing blood pressure to rise. So don't wait until you've risen to the diagnosis. Just when you see a change. So one of the things I say to people, because I'm a medical doctor that deals with learning how to be able to predict these things, knowing when blood pressure will come, knowing when heart disease or cancer, and to be able to prevent it. So the way I do it is to understand what is the body communicating. I don't look at my numbers and my tests as diagnosis. I look at them as information about how the body's doing. So the thing about the reactive is that when you're exercising, it's up. So when you come to a doctor's office and you have a high blood pressure reading and you're in pain, should you get a blood pressure pill for the blood pressure, or should you get a pain control? I won't say pain pill. All right. If you come into the office and you are stressed, and your blood pressure is up, do I give you a blood pressure pill to come down, or do I talk about your stress? Remember, talk about it. There's no fix. There's no quick fix, no drug. There's always a drug. It's a temporary bridge. And if only people understood, there is a time and a place. So where I'm leading to this is, at Next Health is the right treatment for the right patient at the right time. I have to repeat it again because it's very deep what I said. I'm a very deep person, by the way. I may sound like
I can confirm.
The right treatment for the right patient at the right time. Right treatment can vary from what you just said. It could be a vitamin. It could be IVs. Did you know the Finland study showed that the sauna 4 times a week, it reduces, I know you know, reduces heart disease by almost 40–50%.
Yeah.
Right. And the list goes on. So all modalities for blood pressure are not related to blood pressure pills. We're going to talk about that diet.
Yeah.
What is it about that diet? It's nitrates in the diet, right? So we're talking about 2 types of patients. The patient that really has a family history and they've come in 3 different times and it's high, and let's assume that the doctors sort of let the patient relax and did the right thing. If you, by the way, have a cuff that's too tight for your arm, it'll make your blood pressure look higher than it really is. Conversely, if you have a blood pressure cuff too big for your arm, it'll make it look lower than it really is. The blood pressure cuff should be placed at the position of the heart. The measurement, which is all electronic, it doesn't matter. Whether it's hanging on the wall or it's electronic, it needs to be at the, can you see my heart? It's a big heart, by the way. I have a big heart. Yeah. You have a big heart because you're an athlete. I have a big heart because I'm a physician. I'm compassionate, apparently.
Can I ask you a question? Actually, this is something that I've wondered about, and I think you'll give me a straight answer. So I had a friend who is a Navy SEAL and always, even as a young man, suffered from hypertension, right? Assuming maybe there was some ventricular hypertrophy. He was like a power lifter and some stuff, but looked to be, a physical specimen. And he said that he had a conversation with his physician one time, and the doctor told him that, well, it's because your heart is so strong. That's why your blood pressure is high. What would you say in that?
Very good question. So the right answer, Vic, and you're going to listen very carefully, but everybody should listen to. There's no one metric that's going to give you the answer. You may need an echo. You may need an EKG, and I'm going to go over this because you're going to realize I'm a real doctor that understands all of this stuff. And then what do we talk about in an athletic heart? So if you go to an average doctor and they see an echo, or let's just say chest X-ray. X-ray, when you do an X-ray, the air shows up as black in lungs. The heart is a dense muscle, so it shows up as a white shadow. We can actually measure the diameter of the heart. It's actually quite a reasonable way to do it. When we see patients with heart failure, they tend to have big hearts. Now, if you have a shadow, you can't tell how good the heart is, or how much is muscle, how much is the ventricle, the volume inside. You can't tell. So if you have a doctor who doesn't understand athletic performance and sees and diagnoses that X-ray, he's going to say, that's cardiomegaly, a big heart. You must have a heart problem. No. If you take a history, that's an athletic heart. So we're getting closer to answering your question. Next one, an EKG. An athletic heart has what's called a J-wave elevation. That means before the, it's PQRST, right? Anyway, the point is that there is a change on the EKG that shows an athletic heart. If you have a big heart, you have more electrical strength, so the deflections on the EKG is high, and that might be deemed by an average doctor as, well, you must have high blood pressure, because high blood pressure patients tend to have big, thick muscles and they have big deflection, and you seem to look like that. You have to get to the next picture. The echo is probably the better way to look at it, because the echo is a three-dimensional picture, looks at the volume, that means the amount of blood that's going to be in the heart before it's squeezed, the thickness of the muscle, and then you're now getting closer to the athletic heart. The athletic heart will have a thick muscle, because like any muscles, when you work it out, it gets bigger. But the volume of blood is huge, making the combination of the ventricle, which is where the volume of blood is, and the size of the athletic muscle on the X-ray looks big, J-wave elevation on the EKG, and you have an echo that shows that for every one heartbeat, like you're an athlete, every one heartbeat, you have so much blood traveling around your body, you don't need to beat for another 45 per minute or 50 per minute. A real athlete is like way under 60. I'm lucky if I get to 60. So the idea is that you have the lower heart rate in conditioned hearts, and we're talking about average people. We're talking about the elderly with the arrhythmias and stuff. Okay, follow us here. We're talking about
contextual.
Yeah, in the context, right? We're not diagnosing, treating. We're just giving you education information, much better than anybody else. So that's why an athlete has a resting heart rate of 45, sometimes 40. You know, cyclists I've heard, top heart rate of 35. It's like, I'd be dead if it was 35. But frankly, when you're sleeping, that's when your heart rate is at the lowest, because there is no demand. So the point is that athletes have conditioned their heart. So that's kind of the way to look at it. Now, I haven't finished with that question. So there are types of exercise that make the heart muscle thick, but the volume, the chamber is not big. That's a problem. So weight training, because it's a short burst, and there's lots of benefits of weight training. I'm going to be a proponent of it. But if you're just a meathead and all you do is weight training, you have this short burst of power requiring this short burst of blood flow, and then you're kind of resting too much. So then the muscle gets big, but the volume doesn't get big. And that in itself creates hypertension. So now we have to get a history from your guy. Now, was he able to run a marathon? Then that means the chamber must have been big. So that pressure could be an athletic heart. But to be honest, I haven't seen an athletic heart that should have a blood pressure that high. He could actually have reactive blood pressure on top. So it's so many factors going on. So he's got a big chamber. I'm good with that. He has a big heart because muscle, because he works out. He's able to have endurance. So clearly it's working well. Now, we have to also consider the quality of the blood. The quality of the blood, I mean, for layman's terminology, is it sticky? Is it fluid? Sick people tend to have sticky blood, more heart disease, more blood clots. The arteries and the veins are different, but veins, we call them DVTs, sticky blood, deep vein thrombosis. It's quite common, getting higher and higher, but arterial is a little different. But we got to differentiate these things before you label this guy as a problem. And so with him, I would say that with his blood pressure, he could have a reactive white coat anxiety, that when you put a cuff on his arm, his blood pressure goes up. So the point is that there's no one reading that's going to answer that question. But by the time you've got the EKG, by the time you've got the echo, you probably don't need an X-ray because that's old school. And then by the time you look at the quality of the blood, that's what you were alluding to, what I do. I don't just look at the lipid profile. I'm looking at the advanced cardiac, which looks at molecular size of the LDL, looking at dense particles that cause blockages, inflammation that creates risk of a heart attack. All those make things sticky, to keep it simple. And if you have sticky blood and a raised blood pressure, then you wouldn't be so comfortable with that. So the long-winded answer is that get as many metrics to minimize or stratify where we're going. And everything we just said, we can have that discussion for anybody, because at the end of the day, we're not treating remember, we're not treating the number. The question is, why is the number high? For a very simple, very, to make it interesting for people, Even when people have a family history, like both my parents have blood pressure, one had a heart attack and died at 65, the other one had a stroke at 75. I have measured the genes for the angiotensin enzyme. I have it. That means that it doesn't work well. So I am prone. I am the one that can metabolize coffee. So number one, don't drink coffee at night. But those people get more high blood pressure. So the list goes on. I even have the gene for inflammation. I've had it in the past. So let me tell you this. All these genetics don't happen just because of the DNA. You conduct your lifestyle in a way that allows it to come out. So what I have told,
Epigenetics.
Epigenetics.
Right.
So I'm alluding to the fact that I have those genes, but yet I've been able to get around them, suppress the epigenetics. So how was I able to do that? How was I able to do that? The point is that these genes can only be expressed if you allow them.
Right.
If you allow them.
And that's one of the analogies I like is you look at your genetic makeup, and a lot of people think genetic and they think, like you said, this is what it is. I was born this way. There's no getting around it.
And the doctors tell you that.
But the truth of the matter is, when what we're learning more and more is that genes are a lot like a light switch. You can turn them on or off, or turn them one direction or the other to change what you're actually expressing. Like you said, that term expressed, and that's what is being shown in terms of your health. What is your body behaving like? Which switches do you have turned off? What does the house look like when you walk inside? It's like, all right, what lights are on, what lights are off? Well, we can change that through behavior, through lifestyle modification, but it all starts with proper assessment. So like you said, not just going to the doctor to have your blood pressure checked in an environment where you're uncomfortable and you're likely anxious, and it's a quick measurement and it's just this one snapshot in time. No, okay, well, if you have a reoccurring high reading, well, let's try to figure out, before we jump into throwing you onto some sort of pharmaceutical medication, let's try to figure out what the underlying causes are. And that actually brings me to another question that I have for you around the lipid profiles and that component of the cardiovascular screening. And so one thing that I, and you correct me if I'm wrong, but one thing that I was taught was that when we're looking at a lipid profile, we're thinking cholesterol, when we're looking at our HDL, our LDL, our triglycerides. For a long, long time, it's been preached that, hey, you have high cholesterol. That's bad. And this is what your cholesterol is. Number one, that's just a snapshot in time, right? So that's not necessarily indicative of your cholesterol on average, maybe. And at any point, correct me if any of this is wrong. The second thing is you have to think of your cholesterol as a vehicle for the types of lipids, the fats that your body requires, right? So you eat fat, it's broken down into the usable pieces, if you will, right? That the body needs to repair, to regenerate, to operate, to produce hormones, all of these things. Going back to your sticky blood, right? When we start thinking about arterial health and plaques and all of these things, a lot of times what's actually happening is the passengers in the vehicle, so that the types of fats are the wrong types of fats for the body to use. So what happens is the car gets packed and people can't get out because the cholesterol, the vehicle, doesn't know what destination they're supposed to go to. They're not recognizable as the passengers. There's something wrong about these rancid oils that we're consuming, these things that we're eating, and these processed foods. So what happens is eventually the car gets full and you have overflow. And those overflows will then try to find a place. Those patients will try to find a place to hang out. Those passengers, rather, they'll try to find a place to hang out. They no longer can ride around in this cholesterol vehicle. So now they got to find a new home. So they're going to sit on a bench in maybe some area of an artery that's compromised. So they start to settle in, and then more of those guys want to come in and find a place to sit. So they notice that, hey, there's some guys here. I know those guys. I'm comfortable. I'm going to come sit on the bench with you. And with time, you can create blockages. You can create issues that can all lead to high blood pressure. So just to ask the question that I actually want to ask, do you agree with the fact that cholesterol in and of itself is not a good indicator is not necessarily a concern, granted that you have a better understanding of what some of those other numbers are? And if you want to just maybe expand on what those other numbers are, what they mean.
Yeah, let's link it together because we started with talking about blood pressure. So let's just, first of all, just explain that when a doctor sees most patients, they just usually work on one problem at a time because that's how they get reimbursed. A dirty little secret. They get reimbursed, so that's what they're going to do. So one day blood pressure, one day sugar, one day cholesterol. It's like, but the body doesn't work that way. So let's go straight to what you just asked. That we were talking about blood pressure. Why are we talking about cholesterol right now? Because you may imagine that they may be related. Well, at least you should know that the cholesterol is traveling through the bloodstream. How can cholesterol travel through the bloodstream? It's a rhetorical question. How can cholesterol, which is fat, travel in a bloodstream that is hydrophilic, water? It needs to be transported into a structure that can carry the cholesterol. Before we talk about high and low, good and bad and ugly. That is called a lipoprotein. LDL stands for low density lipoprotein, and you're sold falsely, that's the bad stuff. The high density lipoprotein, HDL, is the good stuff. You see how it's going up? It is good. But we're not that simple. Doctors may be simple, but we're not that simple. Let's go into the reality of it. They're just transporters, like you said. That's it. Don't blame them. You know, when we talk about the LDL, the high cholesterol, which is the cholesterol part, I'm going to tell you and blow your mind in a minute. But let me just tell you. The LDL being elevated and cholesterol being elevated in somebody who had a heart attack, blame the LDL, blame the cholesterol. False. Let me tell you why. Number one, when you go to a fire, and if you're looking from the outside down, from outer space, looking at every fire seems to have fire trucks at the scene. Then the fire trucks must be causing the fire. That's the stupidity of saying that high LDL, the high cholesterol is the cause. It's an association, happens to be there. Now you have to ask the question, why does the LDL want to aggregate, stick in that area, which we call a stenosis or a blockage or a atherosclerosis, whatever you want to call it? That stickiness is allowed when the nitric oxide is down. When the nitric oxide,
That's okay.
sorry about that.
Hear you. That's okay.
When the nitric oxide is down, when the nitric oxide is down, the surface of the blood vessel, the inner surface, the endothelium, is more sticky. That's why blood pressure is a risk factor for heart disease, but the common link is nitric oxide, which you can raise with exercise, but then we should actually tell people how to safely exercise if they are pre-hypertensive, hypertensive, blah, blah, blah. That's the link. And your doctor should be having that conversation about blood pressure and cholesterol at the same time, even sugar, by the way. So when you have high sugar, it damages the NOS enzyme, which lowers the nitric oxide again. That's why you should have a conversation about the sugar, the blood pressure, and the cholesterol at the same visit. You can actually kill all birds with one stone if you just make simple steps that are common to all, like the nutrition. Little bit. You don't have to make a major change. Like the blood pressure, you don't exercise. You don't have to be an athlete overnight. In fact, I would recommend not to. Get your body healthy, feeling good, gradually build it up. And we're giving answers to where you should be going. So to answer your question, and the part I'm going to blow your mind is this. This is a general statement, but it's a study. People after the age of 50 who have high cholesterol have better cognition, like me, over 50, and better cognition, because I said so. And secondly, people with high cholesterol over the age of 50 actually have less cancer. Let me explain. That cholesterol is not your enemy. There is a difference between the different qualities of cholesterol. If you consume the toxic cholesterol, the rancid fats, that could be the bad stuff, but plant-based, clean animal fats, the seeds and the nuts and the avocados and the olives and the olive oil and the coconut oil, they're all great. Sesame seeds, these are great. So the question is, why does the body need cholesterol? Because your brain and your nervous system, the sheaths that cover the nervous system, is 65, 70% fat. What do you think your cell membrane is made of? Phospholipids. In fact, the parts of the cell that have the most activity, like where the insulin receptor sits, needs an extra bit of cholesterol called the cholesterol raft. The cholesterol is used to make your hormones. One of the reasons why people have low hormones is that when they don't sleep, then the body gets depleted in the hormones. And if you don't have cholesterol, how do you expect the body to rebuild it? So people who are endurance athletes actually need more cholesterol. People who are older need more cholesterol. My cholesterol has been going up and up. But you know that I've measured the stickiness of my blood, the advanced card. You know, I look at the walls of my blood vessel. You know, I know how big my chamber is. You know, after all of that, I'm not afraid of my cholesterol because it's carrying fat soluble vitamins like A, D, E, K, CoQ10. That's why my speculation, my theory, because they give you study results. They don't tell you exactly the mechanism, and studies are not the end all be all. They give you information for you to be able to figure out, and another study needs to be done. So my speculation, which is probably accurate, is the fact that maybe those fat soluble vitamins, those antioxidants, are good for the immune system, which decreases your risk of cancer. That fat goes to not only repair injuries from inflammation, which, by the way, stress causes damage in your brain from cortisol, but you don't feel it. Those cholesterol go to repair it. You need higher cholesterol as you get older. And what your doctor is doing, and this is a fact, this is not theory, this is not me quietly saying it. They're actually creating an environment for dementia. They're actually creating an environment for low cognition and more cancer.
Yeah,
that's a
that's
fact.
so sad. That's so sad.
Yeah.
So again, a good opportunity just to impart a simple concept for people to take away from a nutrition standpoint is you are what you eat. We all have heard that saying. But the fact of the matter is every cell in our body has a lipid bilayer, right? Like a layer of fat for those people who don't understand the term. None of your body is made of carbohydrates, with the exception of maybe storing some glycogen in the muscle or your blood sugar, as a fuel source. So what I always tell people is like, if you can't change anything else about your diet, you just don't have the ability, you don't have the accountability, you don't have the knowledge, you don't have the time to focus on it, do two things. Limit as much as you can the refined sugars. Try to stick with higher quality sources of carbohydrates if you can. So yams, sweet potatoes, some whole grains, some things like that. But really focus on the quality of the fat that you eat. Get away from, look at a label. If you see any kind of processed oil on there, just steer clear of it. If it's canola oil, all of these things that had at one point in time been marketed as, good for your health because it's low fat.
Low saturated fat.
Yeah. Look for your olive oils. Like you said, stick to whole food items, things that you could recognize in nature, eggs, like you said, avocados, nuts, seeds. Just be sure to take a brief look at the label. And if you see any kind of oil outside of those basic ones, let's just say olive oil or something like that, think twice about it. Do a quick, we all have a computer in our pocket these days. Do a quick Google search the name of the oil you see on the label and rancid fat next to it and see what pops up. If you get a hit, just avoid it. So those two things, I'd say, if you can't change anything else, frequency of eating, amount of eating, type of, just focus on higher quality fats that you could find in nature and try to avoid as much refined sugar as possible. Those two things in and of themselves can make a world of difference if you can do them consistently.
100%. Vic just nailed it on the head. So now the boring doctor is going to go into the nitty-gritty detail, but you nailed it on the head. And you know what you just said will actually treat your blood pressure. Did I say the word treat? Well, I have a license to be able to say that, by the way. Yes, that would treat the blood pressure. That would treat the cholesterol.
We're redefining treatment.
Exactly. That would treat the sugar problem, right? So let me give you the science behind that. It's unbelievable what we just said. So that's why I think that when we're talking about safely embarking on exercise, even if you have blood pressure, if you follow these two simple advice and just listen to your body, go steady. That's the trick, right? There's no way for me to predict what you can and can't do, how long it'll take. It's like anything. You start, see the response, then the next step. That's how we do our medicine too. When we start a medication, just to let you know, I actually can prescribe medication. We don't start at the highest dose because the blood pressure is so high. You have to start in the lowest one because it's safe. And you don't know how much of a response you're going to get. So what if you 10 milligrams does it, then why would you go to 40? And so this is a just common sense approach. And that's what I think is lacking in the medical world. Now, to talk about the sugar and the fats as something that, what is the core between those two things that can drive blood pressure, that can drive heart disease, blockages, sticky blood, that can drive blood sugar, cholesterol, and blood pressure? It is something called insulin resistance. So as Vic said, if you have refined carbs, and we should talk about how to, you said it, root vegetables, yams and stuff. Look, if you follow us, we're going to tell you how to go grocery shopping. We're going to tell you how to make it interesting. After all, that's what it's about. We're going to be able to tell you about fitness and nutrition in a way that's doable, manageable, whether you're at the beginner, middle, or a super athlete. We're going to go through all of that. Why? Because we have the knowledge. That's why metrics are important. That's why data is important. And then a practical person like Vic or me, who does real life medicine as opposed to behind a desk. I'm not behind a desk, am I? No, I'm not. So going back to insulin resistance, there are three actually common ones, but the two, refined carbs, spike your insulin, that causes insulin resistance. I'll tell you the mechanism of how that drives. If you have toxic fat, toxins disrupt the insulin receptor and you have insulin resistance. The definition of insulin resistance is when the baseline insulin level lives at a high level, which makes it dysfunctional. More is not always better. That's how we define insulin resistance, is a baseline at a steady state, constantly at a high level, because the insulin receptor regulates the pure energy source called glucose to enter the cells of the brain, enter the cells of the heart, enter the cells of the liver, enter. So the common thread is you have to be able to get fuel into the cells for metabolism. What do, people throw out these words without understanding the mechanism, and you can't do it if you have insulin resistance. So a lot of people don't eat a lot. A lot of people try to exercise. They can't lose weight. It's beyond weight gain. It is something resisting it. And that resistance is not only from the refined carbs or toxic fat, it can be from inflammation. Those three things or four things, insulin resistance, inflammation, toxicity, refined carbs, are the root of sticky blood. They drive dementia. They drive heart disease. They drive even cancer. So the point is, we started with blood pressure and how to safely exercise. Start with nutrition, not what to take away. So try to be satisfied with your meal. I never talk about calories in, calories out. We are not a combustion engine. We're all about signals. And we will talk about epigenetics and the DNA age, but there's just so much to talk about. But that signal, one of the major signals is insulin resistance. It drives hormonal imbalance like PCOS. It drives arthritis, inflammation. All of these things are detrimental for every organ function. So if you know nothing, inflammation. Refined carbs, inflammation. Toxicity, inflammation. But if you are a little bit scientific, it's what you eat is processed through the bacteria in the gut. The bacteria then decide on which signals to send, and you want an anti-inflammatory signal. So you want to feed the bacteria what it wants. So fats are very safe. Plant-based fats are very good. Nuts, seeds, and so forth. I always end the night with nuts and seeds because I'm a glut. I like to eat something. You can't go wrong with the fats. Even by day, if you're fasting, the fats won't break your fast. If you have too many carbs, it'll break your fast. If you have too much protein, it'll break your fast. We'll talk about fasting as well. But we don't want to jump. We don't want to run before we walk. So does that answer some of the questions about
absolutely.
How nutrition and exercise and blood pressure and cholesterol and heart disease, they're all connected.
Right. Yeah. So if nothing else, that's what I would like everybody to take away from this is, as you can see, it's all interconnected, and there is so much to say. There's so much to learn. I mean, you and we're learning every day, and you've been doing this for over 30 years. I've been doing what I've been doing for the better part of 20. So like you said,
but you look so good, man.
Well, the beard hides a lot.
I was coloring this. So
but I mean, to put a bow on it, because I know you have a busy day ahead of you, I have one as well, so we're gonna have to log off here soon. But what I want to say is, if you don't take anything else away from this conversation to the listeners, is that this is multifaceted, and that it's always contextual, and that if you really want to get proper, let's use the word treatment, and you want to get better, you want to become well, then you need to have someone in your corner who is able and willing to help you do the sort of digging you need to do to get a proper assessment of what is really going on at the cellular level. And that's what you guys, where you start with all of your patients at Next Health, is with executive physicals, things of that sort, right? To be able to look deeply into all of these different facets of the cellular level of metabolism and what's going on inside of the patient's body to try to deduce, okay, well, where are some of our root causes? You're looking for you're looking to develop the roadmap, right, along the way. And it's in real time. That's the thing, is that people have to understand, is that you have to adjust along the way. You can't, oftentimes, I'm sure you guys find this with patients, is you have an initial protocol for how to move forward with the patient. And at some point, something changes for the good or the bad. And you make adjustments in real time. Same thing with what we do with our patients with exercise and nutrition. Is just to answer, just to touch on something that you mentioned earlier, is, for anybody who's listening and kind of queuing in on that, hey, high blood pressure, I can relate to that. I worry about that. I have high blood pressure. What do I do? How do I do it appropriately? Two things. One is you should try to have some professional oversight, right? You should try to have somebody who is expert guiding you and helping you figure out what an appropriate strategy is to take at the onset. You and I, what we do is we try to provide guidance, but you and I also both know that we don't want our patients or our clients to be held hostage to us. We want them to work with us to help them become able to do what they need to do on their own. We want to teach them the tools and give them the knowledge that they have to be able to be self-sufficient. But a lot of our clients continue to work with us because they see that this is a lifelong learning process, and that they find value in maintaining the relationship with us. So when it comes to exercise, just to, again, something very simple for people to take away from this is, make sure you find somebody who can give you some good guidance, and take your time. The goal is, this is the long road. You don't want to go from 0 to 100 and try to become a super athlete overnight. Take your time, listen to your body. If something feels challenging, that's okay. But if something feels dangerous, then listen to that. Okay, take it back a notch. The biggest thing that you can do is be consistent. So if you go from 0 to 100 overnight, chances of you being able to remain consistent with your nutrition, with your exercise, with your anything, are very low. But if you're able to take one step at a time and do a little something each day and turn that into a new normal practice and develop the habit of that practice, then you have a much better chance of gaining some momentum and seeing actual results. A lot of people jump on and off too rapidly because things don't happen overnight. We're used to things being able to happen instantaneously in our country. We're very fortunate in that fact. We're very comfortable. There's a lot of instant gratification, but also, if you're not careful, that can also be to your own detriment, because you start to think all things work that way. So take your time. Again, we offer services like that. So we'll make sure that we share a link to both Next Health and our weight loss and nutrition program and all of that stuff, the different services. Adam will put it somewhere. I don't know where it's going to go, but Adam, you can figure that out, right? So that if anybody does have questions, they want to reach out for free consultation, they want to have a conversation and just learn more, they can do so. But if nothing else, just make sure that they stay tuned, because like you said, there's a lot for us to go into. We touched on a whole slew of things today.
And we'll elaborate on that.
Right. And we'll elaborate on all that stuff. So I'm going to leave my part at that, but Dr. Habib, do you have any closing remarks?
Just a final one is that there's a proverb that says, a journey of 1,000 miles starts with one step. What we do is give you the right direction. So without being too humble about it, we're the expert that's going to tell you what's risky. We're going to evaluate the right path for you. And then, believe it or not, you do much better when you have guidance, right? And we give you very practical guidance. We're not one of those people, well, here's a prescription, we'll see you in 3 months' time. We're hands-on. We have tools, we have capability, we have experience. So assessment is the key. Then having somebody with a lot of experience in a wide range, whether you're an athlete or whether you're just starting out. The fact is that we offer this. That's why we partner together, that whether you're physically in front of us or not, we can do this virtual nutrition, virtual training, even do the medical assessments virtually in certain levels, frankly, right. And which all of these things will elaborate. You talked about epigenetics. We're going to talk about that. We're going to talk about the gut microbiome. We're going to elaborate on inflammation. What type of inflammation? There are people listening to us that have diagnosis of autoimmune disease. They have people listening to us with inflammatory bowel disease. And guess what? They have increased risk of heart disease, right? They probably have blood pressure, but their doctor is going to treat the blood pressure in isolation. That's a real problem, because inflammation that's inside the body is driving it. The insulin resistance that's in their diet is driving it, and they're not getting that advice. So I'm going back to the deep stuff. We're going to we're the experts. We are going to help you. There will be a link. So if nothing else, then at least contact us or look at us on the website, which is www.nexthealthmed.com, www.nexthealthmed.com, 724-4000, 703-724-4000. Reach out to us, text us, call us. We'll do that evaluation just to make you comfortable. But not only do we have the medical expertise, we've got the professional exercise and the nutrition. It can be done in front of you, or better still, virtually, remotely. All right, that's great for today. I can't wait for next week.
All right, man. Next Health, lifestyle medicine. That's what we're after, guys. So thanks for tuning in, and we'll look forward to talking to you guys soon.
Great. Take care. All right. Bye-bye.